In this video, I want to talk about bradycardia, and I specifically want to talk about some of the causes of bradycardia, the things that can cause bradycardia, as well as the consequences of bradycardia. In order to get started, we should define bradycardia, which is generally going to mean a heart rate of less than 60 beats per minute. And we're specifically going to be talking about bradycardia that leads to a decrease in cardiac output or is going to have some symptoms for the patient. For a bit of a review, if we look at our normal conduction pathway, we have our SA node here. It's important to remember that our SA node fires between 60 and 100 beats per minute. So in general, we need the SA node to be functioning in order to have a reasonable heart rate. The AV node is going to fire between 40 and 60 beats per minute, and our Purkinje fibers are going to fire between 20 and 40 beats per minute. Now, that's not to say that the ventricles and the junction cannot beat at a higher rate, but this is generally what we're looking at for their normal rates. So in order to talk about bradycardia, we're going to talk about three main causes of bradycardia. And the first I want to talk about is a decrease in automaticity. And what this means is that our pacemaker cells are firing at a less automatic rate than normal. So if we take a look at our pacemaker potential over here, our pacemaker action potential, you can see our kind of normal action potential or how this occurs. So in our phase 4 here, what we're having is sodium. So this, again, is sodium channels opening, or the IF sodium channels. As the sodium channels reach a certain threshold, we have some transient calcium channels opening. Following the opening of those transient calcium channels, we have our long-acting calcium channels, which are going to actually drive the action potential. And then we have our potassium channels that are going to repolarize the membrane and lead to this occurring all over again. Now, it's the presence of those IF funny channels or those sodium channels that's actually going to allow for this automaticity. So every time we get to around this negative 60, we're going to end up seeing more sodium following its electrical chemical gradient in order to increase the resting membrane potential. And this is what leads to this automaticity. So if we impact some of those things, so say we take a medication that blocks our sodium channels, or we have an electrolyte imbalance where we have more or less potassium versus calcium, you can see that we're going to have changes to our pacemaker potential. That's why we end up having some of these issues associated with medication overdoses or electrolyte imbalance. So one of the first things I want to talk about is a change in our end diastolic potential, or basically we're talking about the resting membrane potential or the membrane potential after or during diastole. And I mean, we have to talk about it a certain way here because this membrane is never truly at rest because the heart is continually beating. We have this automatic function. So our end diastolic potential is indicated here. It's where we start seeing the increase in potential again, or we can outline it here as well. So if you think about what happens, if I decrease my end diastolic potential, or say I lower my end diastolic potential to here, so we have a decrease in end diastolic potential. What's going to happen is if you look at the, even if our rate and slope of increase is the same, we now take much longer to make it to threshold because we have to come up so far that we are going to slow rate. So if you look at the distance between here, this is going to be a time distance, or this is going to be a distance in the number of beats per minute that we can have. So this is quite obviously going to start slowing our impulses. So in terms of a decrease in automaticity, one of the things that can happen is we have this decrease in end diastolic potential. That's going to lead to a decreased heart rate as we move more slowly or we have to move further towards the threshold. Now, that being said, if we look at our threshold, one of the things we can do is just move where the threshold is. So again, the threshold is really dictated by this calcium. So how much impulse is needed to open a lot of calcium channels in order to have this influx of calcium and lead to an action potential. So something where we start maybe blocking calcium channels or we need a much higher stimulus to open them could result in a change in threshold. So say we move our threshold way up here and leave our end diastolic potential the same. So we're still starting from the same place down here, the end diastolic potential. Even if it is exactly the same, we now have this increased distance. So again, as we looked at before, we have this kind of increase in distance between our normal action potential and this action potential with this altered end diastolic or altered threshold, and it's going to slow our rate because it's taking us much longer to reach that threshold. Finally, what I want to talk about is the change in the rate or slope of the phase 4 depolarization. So again, we might be starting and we may have no change to our end diastolic potential. But what might happen is we block our sodium channels or we have a decrease in sodium. What's going to happen is it's going to take much longer, or we're going to see this increased rate and slope, or it's much slower, has a wider slope. And what happens, it takes way more time for us to reach that threshold in order to have this action potential generate. So it's just how the speed at which it's traveling. So again, in pink, what we're looking at is a decrease in rate and slope of our action potential. In green, what we're seeing is a decrease in end diastolic potential. And in blue, what we're seeing is an actual change in our threshold. So in blue, we're actually seeing an increase in threshold potential. And all of these things can lead to a decrease in heart rate because we are changing the speed at which our pacemaker fires automatically. Or these things are going to lead to a slowing of the pacemaker, or making the pacemaker fire much more slowly. So the other thing I want to talk about in terms of bradycardia is conduction disturbance. And this is one of the most common causes of bradycardia, especially in the elderly. People, as we age and get around kind of the 80 and over 80 mark, we start to see deterioration of the conduction pathway. So it can actually just deteriorate on its own and lead to bradycardia. So one of the ways we can see this deterioration is through a full blockage. So if we look at, say, our bundle of his here, what can happen is either through old age and simple deterioration of my conduction pathway, maybe through cardiac ischemia, so someone who has a myocardial infarction, we have this full blockage, or we completely destroy the connection between the top and bottom parts of this conduction pathway. So we have a full blockage. And if you think about the consequences of this full blockage, is now I will have an impulse that's trying to be generated from the SA node to the AV node down to the bundle of his, but the problem is that it's now stopped. It cannot pass here because we have this full blockage. As a result, in order to fire the ventricles, we have a area of the conduction pathway below the blockage that's going to take over and send impulses down our bundle branches. Well, we know that the lower in our conduction pathway we get, the slower our heart rate is. So as a result, we're going to see a decrease in heart rate because this now becomes, or this area here now becomes the pacemaker for the ventricles. And as a result, we are going to have slower contraction of the ventricles and decreased cardiac output. So we can have this full blockage, but to kind of break it down a little bit further, we can also have a partial blockage. So say we take a look at a piece of our bundle branch here, and we look at what's happening in a partial blockage, is we have a normal fast conduction pathway within the heart. So we'll say that maybe this guy in the center here is the normal fast conduction pathway through the bundle branch. And this is what's going to allow us to have, nice normal conduction down through the ventricles. Now, what can happen is I have a partial blockage where maybe this pathway is ischemic, or I have deterioration. Maybe I'm taking a drug that's impacting the ability to have conduction through my ventricles. And what can happen is now I don't have the ability to send an impulse through that normal fast conduction pathway. So my impulse comes down the pathway as normal, but it can't make it through here. And now it's going to go through one of these slower pathways in order to generate an impulse for the ventricle. So it's not necessarily that it's a full blockage or that nothing can get through, but we have this partial blockage that's making the heart have to take a slower pathway. So partial blockage that's decreasing the ability to follow the normal fast pathway that leads to slower impulse propagation down to the ventricles. So that's what we're talking about in terms of conduction disturbance. Now, the final thing that can happen is we can have an ectopic beat or a reentry pathway. So an ectopic beat or a reentry pathway that is going to occur, that's going to take over as the normal pacemaker. So again, if we take a look down at this kind of blown up picture of our ventricle and our conduction pathway, what can happen is we have maybe a group of cells or a cell in here that decides it wants to be the normal pacemaker. So it's firing off impulses out of turn, or it's not, following the normal conduction, and it's sending impulses out through the ventricle. And this could be occurring in the AV node, could be occurring in the bundle his. Again, it can happen anywhere. But you get this ectopic foci that has decided that it wants to send out impulses at its own rate. So this is our ectopic foci here. And as a result, it takes over as the normal pacemaker. Now, depending on the speed at which this ectopic foci is sending out impulses, it could be much slower than the normal rate. It's important to note that this could be just a single cell or a single group of cells. So we could see truly focal impulses. Or this can also occur with reentry pathways. So we typically think about reentry being as being sending fast impulses, but we could have a reentry pathway occurring in the ventricles or somewhere in the conduction pathway that is not sending out fast impulses, but is taking over as the normal conduction pathway to the heart. So these ectopic foci or reentry often occur due to things like ischemia, again, drugs, hypothermia, anything that's impairing our normal kind of impulses through the heart. So we think about what this means for our patient, and we look at our cardiac output equation. We know that cardiac output equals stroke volume times heart rate. And in these cases, what's happening is our heart rate is significantly impaired, which is going to lead to a dramatic decrease in our cardiac output. Again, if you think about symptoms for this patient, a lot of them have to do with this decrease in cardiac output. So things like lightheadedness and dizziness. The patient may feel as though their heart is beating slower than normal. You may see that they're gray. You may see diaphoresis as the patient is trying to increase their heart rate through a sympathetic nervous system response. Patients may complain of chest pain as the heart rate might not be enough to have output to perfuse the vital organs. So we might see chest pain, or we might see signs of other organ compromise. So things like shortness of breath, a decrease in LOA, decreased capillary refill, a loss of pedal pulses or a decrease in pedal or peripheral pulses. And if the heart rate falls too low and our cardiac output becomes too low, then we'll end up seeing cardiac output, but without the generation of actual output, or we'll see a heart rate without a generation of output, which can lead to a PEA, cardiac arrest.